Hi, Senator Scott Jensen. I represent Carver County in the Minnesota State Senate, and I'm also a family physician in the trenches, if you will. I also teach at the med school for the last 30 years, and I want to introduce a friend and a colleague who has some real important information to share today. Kevin.
Yeah, my name is Kevin Roche. I have worked in healthcare my entire life. I ran a division of United Health Group that did healthcare data analytics and research services. I've invested in and sat on the boards of a number of healthcare companies, and I've written a daily blog on healthcare research and policy for over 10 years.
Kevin, thank you so much. You might wonder, why should you bother listening to the two of us? Well, I think that what we bring to the table intersects reasonably well. Kevin has a strong background in data analytics, modeling, being able to critique what's going on. I've got sort of an in-the-trenches experience. And I think between the two of us, we can really focus on facts, we can focus on transparency, but maybe most of all, we can help connect the dots, because that's a huge issue. So we're going to dive in. Kevin, you showed this to me a few minutes ago. This is data that's current as of April 28th. And instead of just looking at big, huge numbers that are difficult to get our hands around or arms around, you broke it into really 25 and under, 75 and over. Could you just take a couple of minutes to share your conclusions as to what this means? And once you share your conclusions, maybe we could take a run at how might that inform policy decisions going forward.
Yeah, so what I did is take the Center for Disease Control current data on death rates in the U.S. population. And I basically broke this into two groups. One is the younger group that would still be of school age, including college, and one is of the very elderly population. And the thing that really struck me when I have looked at this data is the enormous disparity between these two age groups, but we're applying the same policy to both of them. You can see on this side, literally out of 104 million people under the age of 24, only 41 have died. All of those will have had some kind of underlying pre-existing condition. And on the other spectrum, you see that in the population that's over 75, we've got 18,245 people that died, and so you can see the comparison there. And what that says is for every one person who dies in this young group, you've got over 2,000 who are dying there. We are applying policy in a way that treats these all as equal. We are keeping kids out of school, which is depriving them of an education, is causing issues at home. And at the same time, I'm not sure we're doing enough to protect this group, especially the part of this group that lives in long-term care facilities.
I just want to review with the audience. When you look at decimals, we're looking at tens, 100s, 1,000s, 10,000s, 100,000s, millions. We are talking about a tiny number. For comparison, in this country, we have 40,000 people commit suicide every year. Put that in context. 40,000, and that's per 325 million. And we have 41 for 100 million. If we wanted to maybe compare apples to apples, we could multiply that by 3 to get to our US population, multiply that. So we would have 123 people in that age group. 123 versus 40,000 suicides. When you look at this data and you realize that this is informing our policy decisions, we really have to step back and chew on it. Kevin, you made a comment a few moments ago. You said something about applying the same policy to both groups. There's been a little controversy about would it be appropriate to pivot and to have a voluntary self-quarantining for that group of people over the age of 70 with multiple diseases or comorbidities. There was a recent comment by a senator who said that to have a stay-at-home order that would only apply to one part of the population is bad public health policy. And I would challenge that comment because we've never done it the way we're doing it now. If you look at 1918's first swine flu epidemic, we didn't do it. If you look at 2009's second swine flu H1N1 epidemic, we didn't do it. If you go back into the days just after the Crusades and you talk about the Black Plague and the bubonic plague, we didn't sequester a whole community. We knew that there needed to be an underlying fabric of the community still doing the things that needed to be done, whether that was trying to help feed and provide water, whether it was to remove dead bodies, whatever. This is unprecedented. And it's so concerning because this is our way of life. In a global, connected world, we have epidemics every couple of years. If they don't get to an epidemic stage, we usually call it an outbreak. But I mean, we can go through 2002 and talk about SARS, 2005 and talk about avian, 2009 and talk about the swine flu, 2012 and talk MERS, 2014 talk Ebola. In 2018 we had 80,000 people die of the flu, and that year they didn't even call it an epidemic, they called it an outbreak. So this is powerful news that you're sharing. What do you think this graph, this table, would say about what we should do going forward in terms of policy?
Well, I think it's very clear to me that we probably should never have shut the schools down. There's obviously very low risk to school-age children. There's pretty significant evidence coming out now that they may not even get infected at nearly the rates that the general population does, so they're not able to transmit the disease to others, which has been one fear that's expressed. This is an enormous burden. I hear from people all the time about how hard it is to have their kids at home. They're not able to get them a good education that they need. It interferes with the parents' ability to work, and they are being expected to work at home, many of them. Parents are concerned, especially with their older children, about what are they doing with themselves and with all this free time they have now. So it's an enormous, I think, social issue to have all these kids at home instead of in school learning. And on the other end, as I said, I'm concerned, especially in Minnesota, about how adequate our policy has been to protect those people who are known to be at high risk.
Kevin, my first patient this morning was a 70-year-old guy, always been in good health, still works. And he described a non-specific kind of chest discomfort. He said, I just get a little tightness here. And I said, well, what seems to bring it on? He said, sometimes if I go walking it does, but other times I can work really hard lifting bags of salt, going up and down stairs and not have too much trouble. But he said, I'm really feeling stressed. I said, what's up? And he said, well, my daughter had to move in the house because she's got 2 kids that are school age, and they don't have the kind of internet where the kids can learn. So they moved into our house. He said, kids aren't really doing that well with the studying. He said, this just is terribly sad. I think that the impact of literally flipping our society upside down is just really hard to appreciate how deep it goes. We are definitely having people with chest pain, angina, heart attacks, coming in late. I talked to a surgeon the other day. 70% of the belly pain complaints are coming in late, and many of those represent appendicitis. And when they do the appendectomy, frequently they have not been able to remove the entire region that's infected because it's already ruptured. So they go in, try to do as best they can to remove the necrotic dead tissue, grab the appendix and get that out of there, but frequently leave a drain in the belly for 5 to 7 days, use high-dose IV antibiotics in a hospital setting, and all of a sudden, something that frequently can be a 6-hour stay in the ER, diagnose appendicitis, go to the surgery, get the appendix out, convalesce for a few hours, back home, turns into a 10-day hospitalization. We'll talk later about, are we somehow putting that kind of information into the formula? But when you talked about this group population, that made me think we should talk about long-term care. You showed me a graph. Could you pull that graph up about what has gone on in long-term care in Minnesota the last week?
Yeah, so this graph went through April 27th, and it showed the place of residence for people who died in that last week from coronavirus disease. And over here at the end, and on the heading, you can see that out of 144 deaths that occurred in the state in that period, 127 were in long-term care facilities.
Let me say that. So 127 out of 144 deaths that occurred over the last week have occurred in long-term care facilities.
Yeah, that's correct. And Minnesota, unfortunately, this is a category we lead the nation in. The Kaiser Family Foundation did a survey of a number of states to ascertain the long-term care facility death rates as a percentage of their total deaths. Minnesota is at the top of the heap, which is not a good place to be, obviously. And again, people should be aware that this isn't a mystery. When this outbreak started, the first significant place it hit was in a nursing home in Washington State. Everybody knew and was aware that that population was at risk, but yet somehow in Minnesota, we have not managed to protect those people.
Thank you, Kevin. There's no value, I don't think, to playing the blame game. But from what you just showed, to have had a laser-focused policy on shuttering long-term care facilities, in retrospect, might have been a good move. I think Governor Cuomo in New York has said that, and I think the governor in Florida, they've sort of been contrasted, haven't they? Could you comment on Florida and New York in terms of what they did with their nursing home population?
Yeah, I think in Florida they did a better job of shutting facilities down more quickly, limiting access, looking for infections. New York, as I understand it, at one point was actually transferring coronavirus patients who were in the recovery rehabilitation phase of the disease to some of the long-term care facilities, which are used for that purpose as well as kind of a permanent residence. And obviously when you do that, the risk you're creating is pretty significant. If I could make one more point about the chart here, especially in terms of, as you said, about the public policy, the other thing that's really stands out to me, aside from the disproportionate burden we're putting on people, is we are really scaring people unnecessarily. You know, this group has very little risk of any serious illness. We have terrified people into thinking that, you know, young children are going to get sick and die, and it's really not happening. And it's important, I think, not just for people's mental health, but also if we are ever going to get the economy going, people can't be so afraid unnecessarily to go out and do the things that they used to do.
We want to try to stick to facts and transparency and connecting the dots, but forgive me if I take just a little license. Our Constitution says something in the preamble to this effect: secure the blessings of liberty to ourselves and our posterity. Our posterity references future generations. And I think what you're saying is, we're asking the younger generations, we're asking the people between 0 and 25 and 25 to 50, we're asking them to make a tremendous sacrifice. It's hard to talk about death, and even it's hard to talk about long-term care because there's so many sensitivities to it. But if you actually look at the data, from the time a person is admitted to a nursing home with the intent of long-term care to the time they pass, data exists that's very solid data that indicates the average is 13 months. Now, granted, if you go to a nursing home to convalesce after a joint replacement, things like that, that's a totally different picture. You're rehabbing. You're actively convalescing. But if we talk about the population that is probably just completed their last domicile move, they've gone from private living or an apartment to a nursing home, 13 months. And we are absolutely crippling family units, jobs, the economy. You reference a pandemic in panic as much as a pandemic in some fearful disease. You told me that a couple of disturbing things that you pondered quite a bit was what we're not seeing from, if you will, the governor's office. I think one of them was what you're not seeing a model for. What was that about?
Yeah, well, we've all seen the models that the state has produced about what the course of the epidemic might be and what some mitigation of spread measures might do to that. What we were not shown at the time the governor issued his orders, and I am not sure existed, was what would be the impact of those orders? What would be the economic impact in terms of jobs lost, businesses that had to shut down? What would be the non-economic harms? Because there is a well-established literature showing that when you have recessions, certainly depressions like we're enduring, that more people commit suicide. There are greater rates of child and spousal abuse. Divorce rates go up. Mental illness rates go up. All kinds of bad things happen.
I'm going to interject if I could. You said it very well, but from a medical side, opiate use goes up because we're not taking people to surgery and fixing their pain syndrome. That's one. Weight goes up. Blood pressure goes up. So on the medical side of things, you also get it.
Yeah.
So you were going to go ahead and finish your comment.
Yeah, and so I just think, I hear sometimes from people who say, well, it's about lives on one side and money or the economy on the other. And that's not it at all. It's about some lives here and some lives here. And that's a hard choice, but that balancing has to be done. I don't think the governor did that. I don't think that anybody created a model or did analyses that would allow that kind of balancing and would let the public do that kind of balancing of harms between the epidemic and efforts that might be taken to slow its spread.
So what you're saying is that the potential harm really wasn't factored in to some of the policy decisions possibly. I think one thing we probably could study pretty quickly would be literally the consumption of alcohol. I had a patient in earlier today and he said, I had to tell my wife she couldn't come in. And I said, well, why didn't you bring your wife in? Well, I don't know if I would have liked what she had to say. And I said, well, come on now, be honest with me. What would she have said? Well, that I'm drinking too much. Well, let me tell you, folks, I'm hearing that a lot. So I don't think there's any question. It's not just opiates and more medication. It's alcohol. And that alcohol leads to more abuse. And the hotlines can attest to that. And certainly in this area, we've seen numerous suicides in the last month. In Florida, there was one county, I think, that had 9 suicides over a relatively short time span. What do you think, Kevin, in regards to the ongoing briefings that Minnesotans are receiving from the governor's office in terms of trying to create a model or factor in some of these less convenient or measurable things? Because the nifty little dashboard that kicks up the number of new cases and the number of new deaths, that doesn't grab onto the consequences that you and I are talking about.
Yeah, I think that's absolutely right. And I think that what Minnesotans are really entitled to see is not just those cases, hospitalizations, deaths from coronavirus disease, but to see on the other side of the scale exactly what's happening because of the shutdown and stay-at-home orders. And that includes, at this point, we know there's 535,000 jobs that have been lost, but the state health department and other agencies definitely have access to data on things like what has happened to suicides, what has happened to mental illness, what's happened to opioid abuse, all of those kinds of things. That kind of data is available, and I think people need to see that so that they understand, while there's not much risk over here, these shutdown and stay-at-home orders are creating harms, many harms to health themselves, and I think that has to be balanced. And I think if people see it, they'll understand that it needs to be balanced.
I want to use you as a bit of a checkpoint for me, if you will, because you do have more expertise than I do in this field of data analytics and that. But one of the things I've been troubled by is when we first started moving towards mitigating and suppressing. We wanted to bring in social distancing because certainly covering one's mouth, coughing into their elbow if they have to, using a tissue, don't touch your nose, your eyes, your face, doing all those sort of common sense things that Minnesotans are raised with, that matters. Social distancing of 6 feet, whether 6 feet is the magic right number, I think that's debatable as well. There's been some good research by Dr. Streeck out of Germany, who has said that Americans have been willing to sacrifice science at the altar of panic. And I don't disagree with him a bit. I think we're doing things that represent throwing mud at the wall, seeing what sticks. I mean, quite frankly, if you look at the porousness of some of the masks being worn, there's studies out there that indicate 90% of particulate matter will get through a cloth mask. More than 50% of particulate matter will get through a surgical mask like this. The N95 mask is only, if you will, assured to protect against particle size greater than 0.3 microns, and even then it filters out 95% of 0.3 micron size or larger, but viral particles are 0.1 micron. So we know that even there, this is by no means some magic bullet. But I guess what troubles me the most is when we said we're going to do social distancing, we did the stay at home. The objectives were identified. They were, we want to flatten the curve, depress the curve, move it downstream, so that we could prepare in our hospital facilities to give ourselves the capacity to take care of the potential surge and peak demand. It appears to me we've done that. Right now, Governor Walz has indicated in his own modeling that we could choose scenario 3 or 4. If we choose scenario 4, we continue across the board, stay at home, devastate the economy further than it's already been devastated, including the supply chain interruption for a lot of our food products. And if we do that, we'll have a peak in July, and he's calling for 22,000 deaths and 3,700 ICU beds being needed. Mm-hmm. I think both of those last two numbers are inflated, but I'm not going to quibble. If he goes with scenario 3, the peak won't be in July, it'll be in June. And the 22,000 death prediction holds, and the 3,700 ICU beds holds. So I'm saying we'd be better off having the surge, the peak in June. We know where we're at. We have seen influenza virtually fall off the map, according to MDH's data. So we're at a spot where it would be the focus of our attention. The further we push it away from us, if we move it and it isn't happening in July, it doesn't happen in August, but then happens in September, and all of a sudden we have an early flu season. We have flu on top of COVID-19. If you could comment on these moving goalposts that trouble me, and then also, could you comment on that intersection of influenza and COVID-19 in some people? Thanks, Kevin.
Yeah, well, I have thought for a long time that the appropriate way, which the Minnesota modelers did to some extent, to look at the epidemic was to run what it would look like without any kind of attempt to slow the spread, and then to try to bake in what would happen in different scenarios. And as you indicated, it is absolutely clear in the model run information that they've given us that at this point, there is no difference between a general stay at home and a stay at home that would be more focused on that vulnerable population. So it's really hard to understand why you wouldn't move to a different approach. I do think that there will be more than adequate resources to handle the care of whatever number of patients need care in the hospitals. There is in the research some clear overlap between people who have both influenza and coronavirus, and so I think that gets commingled a bit in some of what you see. But as you said, influenza has a pretty clear season. We're running at the end of that now, and so that's another reason why as we head into the summer there should be plenty of healthcare resources to take care of whatever number of cases need them. And the other point I'd make, which is made with increasing frequency appropriately, I think, is, the one country that really adopted, I think, a much more sensible policy is Sweden. And initially, when they took some mitigation measures, they don't have large gatherings. They do encourage people to work from home. They kept the schools open. They let people keep their businesses open. They let people go to bars and restaurants. So they did not do this massive shutdown. People said, well, they're just going to see this enormous number of cases and deaths. They do have a lot of cases. They don't have a lot of deaths compared to other countries in Europe. They have a far lower death rate per capita than New York State has experienced, for example. So I think everybody's going to be looking at Sweden pretty soon, and they expect that they will be at kind of population-based immunity within a few weeks. And at that point, they have little to fear from any resurgence of the virus. The rest of us, as you said, for example, here in Minnesota, would have to keep going forever to keep that from happening.
This population-based immunity you referenced it's oftentimes referred to as herd immunity. My wife being a veterinarian, we do talk about herd immunity in cattle and things like that. It was actually, I thought, encouraging to see some of the data coming in from Los Angeles, Santa Clara, various pockets in Massachusetts, even New York, where we're starting to see potentially 20% of the population has developed antibodies to this. I think one of the casualties that we're going to see moving forward is the quality of data. Influenza is not even being tested for. We're, if you will, lumping together any kind of apparent viral respiratory infection into a COVID-19 kind of picture. And that's going to prevent us from comparing apples to apples and oranges to oranges. But it is what it is. I think that moving forward, perhaps a comment about Dr. Fauci. Dr. Fauci has a tough job. I think he has made some statements that he probably regrets. I believe in January he told us as Americans, we don't have anything to worry about. And in February he told us that we could certainly go on cruises and we don't have to, hesitate to do that. Not too long ago, he made the comment that there will be no vaccine put together in less than 12 to 18 months. Fact of the matter is, this is being fast-tracked. Pfizer has indicated that they may have a vaccine available in September or October. Some of the countries in Europe have said, we are going to go ahead and potentially start trials. Because we've been able to identify the base sequence, the adenosine bases, we really were able to get the jump on that. So I think that's great news. We're going to most likely get a second wave. If you look at other epidemics we usually do, probably be in the fall. Many epidemics will have 3 waves: spring, fall, spring. We do need to develop herd immunity. We can't rely on a vaccine, but I think we can be encouraged by that news. Today what we're trying to do is we're trying to talk about facts. We're trying to be transparent, and we're trying to connect the dots. So, thank you so much for listening. Thank you, Kevin. Your expertise is so appreciated, and I am sure that when people see this video, they'll thank you for your thoughtful, calm, rational perspective that you are calling for policymakers. Allow this kind of information to inform our decisions. Thank you.
Thank you.